we're now going to move into a full in-person panel, which is a complete delight. My name is Vikram Patel. I'm a professor of global health at Harvard Medical School. And today I am joined by three wonderful panelists to discuss a subject that has been actually pretty much cross-cutting over the last couple of days. I think you'll all agree with me that I don't think ever before has the subject of health been so much in the spotlight, not just in South Asia, but in fact around the world. Of course, thanks to the terrible pandemic that has hit all countries of the world to varying degrees in these last 2 years. I'm reminded yesterday in Professor Sen's remarks when he talked about the narrowing of the horizons, the narrowing of thinking in India. Amongst the various implications he spoke about was how that narrowing was leading to the neglect of other issues that were of such great relevance and importance to the people of India, and he specifically mentioned, if you will remember, healthcare. Earlier this morning, we heard from Reza from the perspective of Pakistan's response to the pandemic and described how a completely non-health intervention, an intervention that sought to actually support those at the weakest margins of Pakistani society, could be supported when the pandemic was going to affect their livelihoods. Really, again, reflecting how when we think about health, we need to think beyond the narrow biomedical sector, in addition, of course, to having good quality healthcare accessible. Today I'm joined by a panel that promises to be the most disruptive panel of all, because of course the subject of health during the last 2 years has been very disruptive. It's been very controversial. Many of you will be following the, I would say, almost unholy dispute between the World Health Organization and the government of India that has unfolded in the last month around the numbers of people who may have died in India during these 2 years of the pandemic. It is telling that a multilateral organization whose chief scientist is in fact the former head of the Indian Council of Medical Research is now at complete loggerheads with the government of India on the actual numbers of people who died. You think that the numbers of people who died would be something that could be easily settled, but in fact it hasn't. And I think this is just one more example of the enormous amount of disruption that's happened in these last 2 years thanks to the pandemic. Today's panel is really fabulous for many reasons, not only because we're going to hear about examples of these disruptions, but most importantly, what we can learn from what has happened in these last 2 years towards a much more holistic, comprehensive healthcare system for all peoples of South Asia. I'm also delighted that this is truly an interdisciplinary panel. Today I'm joined by Mushfiq Mobarak, who is a professor of economics from Yale University. He will speak first, after which we have Satchit Balsari, who is a physician scientist trained in emergency medicine and works here at Harvard Medical School. And then finally, Sabina Rashid, who is an anthropologist, who is also the dean of the BRAC University's School of Public Health. So the plan now is that we're going to have each of them present for about 10 minutes, and then we're going to throw it open for discussion. And I'm going to invite Mushfiq to go first.
Thank you so much, Vikram, and thank you to the Institute, to Tarun for the invitation. And I say this as someone who actually, like Tarun, was leading Yale's South Asian Studies Center, that this is really impressive. You know, and such great representation on South Asia from Harvard Business School, Kennedy School. I know my friend Asim Quad just been joining online. Medical school, School of Public Health, etc. It's really, truly amazing. I'm beginning to think this is a pretty good university. And I should also apologize by saying I'm a little bit of an interloper in a public health panel. So roughly 2.5 years ago when the pandemic started, I knew very little about public health or viruses. But I was forced into thinking about it just because we all were, right? The government of Bangladesh, I'm from Bangladesh, and the government as well as public health, other policy responders like large NGOs like BRAC, they all needed support, and it opened up doors and it allowed us to work together. So I'll tell you a little bit about what I learned over the last 2 years about resilience of our public health system and how countries like Bangladesh and low middle income countries should be thinking about preparing for crises like this. Okay? So in fact, I'm just going to steal some slides that I used last week at the World Bank, and I was speaking to World Bank country offices like on how knowledge-focused organizations what lessons should we take from there. And I didn't really, I guess you were talking about Dr. Swaminathan. Yeah, so I'm going to WHO, and I'll use these same slides next week, and at her invitation. So, I only have 10 minutes, so I kind of just deleted some slides, so the lesson numbers are not going to be like full. Okay, so I'll start with lesson 2 here. Right? So. Yeah, exactly. Like, in the Q&A, we can go back to lessons 1, 3, and 5. Yeah. So. So the first thing is, let's think back to March 2020. Okay, the pandemic has already hit the rich countries. It was unusual, unlike Ebola, Zika, etc. It hit rich countries like US, UK first, right? And then, as we heard this morning, countries like Pakistan, Bangladesh, we were deathly afraid of what was about to happen, given the congestion, poverty, population density, and weak healthcare systems, right? And one of the things, if you put yourself in the position of a leader in one of those countries, what happens is that now things are about to get really bad, regardless. Okay, so either there'll be escalating virus numbers if you don't do anything, or you impose lockdowns. And in poor countries, that's very, very dangerous to do. Right? It's very dangerous because large segments of the population are in the informal sector. It's not easy for us to get support, right? And it's going to lead to huge economic crisis. So this is why an economist got involved. This was a crisis that was as economic as it was public health, especially in low and middle income countries, right? So in that stage, what would a politician do, right? So what would be safest for them to do is, look, I'm going to look bad anyway. If I just copy whatever, what I'm hearing on BBC, CNN, et cetera, what the US and UK are doing, right? At least I have some protection that I'm following best practice. But if I go on my own and try to design my own policies and then I look back, my political challengers can use that and make me suffer, right? And so that meant that it was difficult for people to make decisions like openly, right, that might have been the best fit for their country, right? So, and I think it was it was a responsibility of people like us, academics, to at least free them to think a little bit more openly about this. So that's what I ended up doing. So this is a paper I wrote in March 2020, modeling. So you might remember the Imperial College model from which like flatten the curve, et cetera, came. So what I did was, let's take that model and just calibrate it to developing country data, Bangladesh, Pakistan, Nigeria, et cetera, instead of rich country data, instead of the UK data, right? And ask the question, I'm not going to change any assumption in the model. I'm just going to calibrate it to different data and ask the question, do you get a different answer? And yes, you do, right? This is why I wrote up in Foreign Policy this article that ended up going viral in the right circles and among policymakers, which was that poor countries really need to think twice about social distancing. Not that I'm telling you exactly what the right answer is, but we need to think a little bit more flexibly and openly. So you get a different answer, and the reason you get a different answer, one, on the left side, is that the age distribution of the population is very different. We already knew that COVID was very deadly for the elderly, but the population in poor countries was much more youthful, right? And second, right, we were flattening the curve because you want it to not rise above the healthcare capacity line where you get excess unnecessary deaths. But imagine you're in rural Bangladesh or rural Sierra Leone, another country where I work, and the healthcare capacity line is down here. By flattening the curve and delaying infections, you don't actually save many lives if you just delay infection for 3 months, because it's not like hospital beds and respirators will magically appear 3 months later. Right? So the benefits of social distancing were a lot smaller. So then you want to start thinking about costs. So then we immediately, in March and April, we started collecting data from household surveys in about 15 different countries, right, on what was happening. And what you learned was, like, this is the value of sort of collecting data on samples that you already had. You have a lot of baseline information. And you see in the bottom left here, right, that after the lockdown, there was unprecedented drops in income and employment and unprecedented increases in food insecurity even during a harvest period, right? And knowing that this was the harvest period, not the pre-harvest lean season, that was also important, right? Because it could get worse. So that's one lesson, which is that, look, we need to think about our own solutions, right? Not just copy whatever we're learning from UK policy, right? Now, this was politically contentious, right? So in Pakistan, by the way, I love the love fest that happened this morning that we all connected between India, Pakistan, Bangladesh. Now, just to give a bit of another story. So I wasn't really working with the Pakistan government in any way, but it turns out that the planning minister, Asad Omar, had gone on TV and said, this Yale study says we should forget about lockdown, so we're going to get rid of it. And then one night, my Twitter and WhatsApp and email blows up saying, are you okay? This is so unfair. So what happened was the Dawn newspaper wrote an op-ed that says that this economist of Bangladeshi extraction doesn't care about Pakistani lives and is advising us to kill thousands of Pakistanis. I don't know why Bangladeshi extraction mattered, but whatever. So you know, it's not that you know, everybody agreed that this was. I want to just give you that caveat, right? That it could have been, you know, depending on the country, it may not have been the right idea either. Okay. Another lesson that, yes, I'm skipping over lesson 3. So the second even-numbered lesson is that LMICs also had a lot to offer, and we could teach each other a lot, right? So I think a mistake that we made in South Asia is that we look a little bit too much to get policy guidance from the West, right? Whereas the other country where I worked, Sierra Leone, what I noticed was relative to Bangladesh and Pakistan, right, their early pandemic responses were stellar, right? And why? They had Ebola experience, right? It's not, you know, Sierra Leone is a much poorer country than Bangladesh is, right? And has much worse healthcare capacity than Bangladesh does, right? But there were things, you know, this picture, for example, that the New York Times used there is of a Veronica bucket, right? At that time, we didn't know that it was, you know, how COVID was spreading. But for Ebola, they had this very simple contraption that was everywhere before you enter any building in Freetown, before you enter remote villages, that forced people to engage in better sanitation behavior, right? And that's just a simple example of a frugal innovation that that might help control the spread of disease, right? Yeah, and then this is around the time that our president was talking about shithole countries. So I made sure on November 3rd, day of the election, we wrote this about what the US can learn from shithole countries. And another thing is that it's not only that countries could learn from each other, it also became apparent that the WHO, the CDC, as impressive as those organizations and the talent that they have, they also had a lot to learn. They screwed up big time this entire pandemic. Okay? So, and one example of this is masks. And by the way, that's how Satchit and I originally connected. So we ended up running, you know, we learned that the WHO was being wishy-washy about mask guidance, partly because they claimed, okay, we don't have strong enough evidence, randomized controlled trial-based evidence. So I talked to Dr. Swaminathan, and we decided, okay, we're going to just provide that. And in Bangladesh, this is something that you can do in a country like Bangladesh or India or Pakistan or Nepal that is hard to do in the US. We launched a trial, right, where it was a randomized controlled trial involving 350,000 people, where we collected blood samples in order to credibly test and then establish that mask wearing indeed does reduce COVID transmission. Okay, and without that guidance, it was difficult for an organization, WHO, for saying something, because their claim to us was that, oh, look, we don't really know if masks work, right? What if people take a false sense of security, they stop doing other things that are sensible, like social distancing, okay? So we provide that evidence, and then here's the new innovation that we learned. So now, if you want to provide evidence that masks actually work, you have to get people to wear masks, right? Which itself, by the way, we all know, most social scientists in this room would know, this is why interdisciplinarity is important, that behavior change is very, very difficult, right? It's not only about whether masks work to prevent the virus, we also need to know how to get people to wear masks, okay? So that's what this picture is about. We did free mask distribution, provided information, did secondary distribution in mosques, reminded people, like politely harassed them to get them to remember to wear masks. And that led to about a 30 percentage point increase in mask wearing, and that 30 percentage point increase in mask wearing translated into a 10% reduction in symptomatic seropositivity, right? So there was a significant reduction in COVID seropositivity in these treatment villages where we were able to promote masks, okay? So that did lead to the WHO changing their guidance and CDC changing their guidance. But more importantly, right, I think that mattered, of course, but more importantly, right, we pushed the study out not only in an academic journal, but through the media as well, right? And that led to some more important changes, which is how Satchit and I originally connected, okay? Which is that the partnership shouldn't only be about research, right? That governments also needed implementation support. So we ended up providing, distributing since, until Omicron hit, we distributed about 115 million masks in India, Pakistan, Bangladesh, Nepal. Mostly there, but Bangladesh got a lion's share of this. And by the way, that American donations from Haynes was a large part of that. Donations from Americans to ship those masks were also a large part of that, and we should give them credit as well. And so continuing this morning's Love Fest, so around this time, Satchit and I actually wrote an op-ed together, along with the co-author from Pakistan, Mahariman, from LUMS that came up this morning. And we simultaneously published it on the same day in major newspapers in India, Pakistan, Bangladesh, and Nepal, in the Indian Express, Dawn, Daily Star, and Nepali Times, right? About how developing countries, or South Asia in particular, needs to coordinate and collaborate in order to address this crisis, right? This is like just post-Delta, but before Omicron, right? So I don't know, we were maybe youthful exuberance. We thought this might help, but now one of the things we learned immediately, this is just amusing, that our Pakistani co-author could not actually access the Indian Express to read her own article. So we have a long way to go. Okay, and finally, I'll stop here. That this research implementation support I'm talking about is still necessary, right? It's still necessary because this is what vaccination rates look like, right? South Asia vaccination rates lagged. And we've now started catching up. In Africa, it's still a problem. Okay? And why is it a problem in Africa, right? So pharmaceutical companies in the US, and they've claimed that it's all about, vaccine hesitancy, right? So we continue collecting data in those 15 countries, and we learned that in every single low and middle income country, vaccine acceptance is higher than it is in the United States. So just on the face of it, this is just BS, right? That's not an excuse to not send vaccines. Okay, and it's much higher than it is, acceptance much higher than it is in Russia. It's not that. However, access is very difficult. You need last mile delivery to get vaccines out, right? So even in South Asia, you see vaccines were taken up in large scale in urban areas, and it was very slow in rural areas. In Africa, rural areas are more remote because of lower population density, right? So in our data from across Sierra Leone, we're learning that it takes 3 hours on average to get to a vaccination center each way, right? And in a country where people are living on $1.50 a day, they're not going to spend 2 weeks of their wages in order to get a vaccine. They're not vaccine hesitant, but they're not that vaccine eager. You and I wouldn't take vaccines under that condition either. So more work needs to be done. Thank you.
Thank you very much, Mushfiq. Thanks so much. I'm sure there's a ton of questions that people have, but for now, we're going to press ahead with the next member of our panel, Satchit.
Thank you. And thank you, Mushfiq. Good to finally meet you in person after many Zoom calls. I will attempt to bring a clinical voice into this conversation, both as a bystander, as a physician, and then a friend and a family member of people who have suffered a lot and continue to receiving healthcare in India before the pandemic, through the pandemic, and after. I will frame my remarks in sort of by describing three crises: a crisis in integrity, a crisis in information, and a crisis in imagination in healthcare in India. I'd like to start with the crisis in integrity with a few examples that we're all very familiar with. When in the middle of the biggest public health emergency of our times, if our apex medical institution in a very large country in the world, our apex research organization, collaborate to continue to publish medical guidelines that are against the face of all evidence that is available in the world, that is available at the tip of your fingertips on the same device through which we attend WhatsApp University, we are in deep trouble. It was only in August 2021 that after several of us published in scientific journals and in the media calling out that drugs like doxycycline and ivermectin, which are extraordinarily useful medications, but completely the wrong medication for COVID-19 were still being peddled by these very powerful institutions in India, we had a huge problem on our hands. Physicians in India don't necessarily have the resources to do the kind of evidence-based medicine training that we offer in the United States, don't have access to the information as easily. And so it is wrong then to entirely blame the medical profession for continuing to push these medications, which are increasingly expensive during the pandemic, onto people who can seldom afford them when the apex institution is asking them to do so. Amongst the most elderly, it was highest amongst the 40 to 60-year-old, which begs the question, what was happening to them when they went to the hospitals? And what was the role that healthcare professionals and healthcare institutions played in the treatment of people from 40 to 60 who showed up at these hospitals? When a parent in January 2020, pre-pandemic, was in one of the finest hospitals in India, I had to camp out outside their bedside in the ICU for 10 nights because at night the ICU was staffed by Ayurvedic doctors. That one of India's finest hospitals could pull a stunt like this and be forgiven for it is deeply disturbing. And it questions the integrity of the entire profession. We're also not genuine about the care we provide to our masses. If you look at any guideline on any non-communicable disease across the subcontinent, it talks about modifying diet and lifestyle changes. I think it's very insulting to tell a wage worker in India or Bangladesh or Pakistan to modify their lifestyle. What does intermittent fasting look like for someone that doesn't have enough food? What does a high protein, low carbohydrate diet actually look like for these villagers? Has anyone done the backbreaking work of studying what the local grain is available? What are the local food supply available? What is the amount of heat and fuel energy you're going to need to eat a diet that is either not going to make you malnourished or obese? And to therefore tell someone that can barely eke out a decent living that they should modify their diet and lifestyle is extraordinarily insulting. The crisis in our imagination is what played out during the pandemic. As Professor Mobarak was just explaining, we were building hospitals and ICUs when we had no one to staff them, and we continue to. The need of the hour was wages to establish food security. I was just speaking to a very large women's organization in Gujarat a few weeks ago. By day 3 or 4, if you are not able to access your cash, which you couldn't because the entire nation was locked down, you are in deep food insecurity before the end of the first week, and the pandemic went on. The lockdown went on for months. Conversations about revolutionizing healthcare on the subcontinent are drunk on the slogans around big data and AI. We are focused on the delivery of care. We are focused on the monetization of care. And I call this the pizza fallacy. We're limited in our imagination by thinking we need to tap a piece of glass and someone shows up to our door to provide us some service that we need. That works nicely for our material needs in Amazon, but that is not what care will really look like in the future. I want to pull up this picture, and it'll be a segue into what I'm hoping Professor Sabina will talk about. This is from 19th century London. In 1858, and appropriately so, I suppose, a year after the Sepoy Mutiny, London was experiencing the Great Stink. It was because all the sewage was being dumped in the Thames. And it was then that Parliament passed the act which allowed London to build an extraordinary sewage system, which is only now breaking at the seams. And you know, it was a moonshot. This is actually a photograph of the sewage pump and not King Cross Station. It was a huge investment in public health. If we want to prepare 2 billion people across South Asia for the healthcare needs of the coming decades, we have to think about what the biggest determinants of health will be. And those will be the food they eat, how we move, and what we breathe. We share waters, we share soil, we share air across these 3 countries. The conversations need to be around how do we declog our extremely dense urban cities, which are going to get much worse, because as the heat waves make land more unarable, people are going to move to these cities. People are going to have to abandoning our coastal regions. Where will they live? How will they live? What will they eat? How will they move? Our parents and grandparents are moving a lot less now in India than only a generation ago. And we all know that the hundreds of millions who live on daily wages cannot actually be running on treadmills every morning. And the last crisis is a crisis in information. Vikram alluded to this. India is a data-rich country with little information about the healthcare needs of its people. We continue to use physicians and our million foot soldiers, ASHA workers, as data collection tools. It is unimaginative to put tablets in their hands and have them click essentially what are digital versions of the analog world. They do not need to be filling forms. There is no other profession in the world where you have to document the process of service delivery like we expect healthcare professionals to do. This is a horrible idea from the United States that we have exported and lapped up in the developing world. If there is natural language processing and machine learning from our smart colleagues in Bangalore that should be applied to healthcare, it is not to figure out how physicians think. It is to liberate physicians and community health workers from collecting data for policymakers. That, to date, they do not know how to use. I think there is this opportunity that Mushfiq was talking about, and institutions like the South Asia Institute allow for this cross-border dialogue. I think it'll be foolish for us to continue to have these conversations at a national level. The population health challenges that we are facing, given how interlocked not only our cultures but our geography is going to require fairly serious correspondence, communication, and joint practice between the nations of South Asia. Some colleagues here that we've invited to attend the symposium with us are driving something called the Community Science Alliance, where we're saying, can we work with community-based organizations across India, Pakistan, and Bangladesh, starting right now in India, to bring to bear the science and the evidence we have in the service of the people? If the institutions fail, do we sit back? Or can we actually use the devices that are in people's hands to contextualize, as Mushfiq said, right? To contextualize the science that we know in the West, to apply it to the service of our people through the knowledge that is available locally. There is no shortage there is no shortage of the right kinds of people we need to deliver this care. I'll close by bringing it back to the question of integrity. While our largest institutions have failed, our foot soldiers continued, right? No ASHA worker is, the amount of work that our community health workers are doing, it cannot be justified by the petty allowances we are paying them, right? And I think we need to figure out how to leverage our communities, our societies, to deliver the care we need without relying entirely on the markets to rise to deliver this service. Thank you for listening.
Thank you, Satchit. I'll now invite Sabina.
I think it's good afternoon by now. Is it still good morning?
Good morning.
Good morning? Okay. Hi, it's a pleasure to be here. I'm professor of I'm a medical anthropologist by training, and it was very interesting listening to Mobarak and Satchit because I'm going to tell you the stories behind the numbers. I've spent most of my working life in Bangladesh, since '93 actually. I joined BRAC, the NGO, in the research division, then joined the School of Public Health, the BRAC School of Public Health, in 2004. I'm here for a couple of months to do some writing, but it's really an honor to be part of this panel. So I'm going to talk a little bit about residents, because I've been working in slums since 2000. And I spent a lot of time in the field collecting what we say evidence, but spending a lot of time with people. And I really want to talk about the human dimension of public health, because somehow we've forgotten what it is to be a human being, to survive, to struggle, and to be permanently in a poverty trap. Marty alluded to this earlier, but I really want to talk about, you've got 4 million slum settlements in Dhaka City, one of the largest. We're becoming a mega city, unplanned urbanization. Governance, well, less said the better. I'm not going to talk about our successes. I'm talking about those who live off the scale. They're sort of the margins of the margins. They're the really people who are living on the periphery, who live life on the edge. And they did live life on the edge before COVID, but COVID didn't help. And I know that Vikram and Richard had written about the social justice and context models around lockdown and the disconnect, because I'd written about it. And I thought it's very important, this point of we went immediately into lockdown mode, but I'm working with street hawkers. I'm working with domestic maids. I'm working with young girls who work in garment factories. 10 million maids lost their jobs. 2.5 million hawkers suddenly didn't have anyone to sell their wares to on the streets of Dhaka. So let me tell you about Meena. Meena I've known since 2006, because I used to volunteer at a drop-in center. That was more out of personal interest, and I've been working with her. She called me and said, Appa, there's a lockdown. What do we do? Do you know what's going on? Because the government had declared a holiday. And they didn't say how long the lockdown was going to go on for. For people like us who are privileged, who sit in our rooms with our housing, food, and rent, doing Zoom, life was most scary about COVID and whether we die from the disease. For them, it was hunger. And Meena called me and said, Appa, what am I going to do? My employers fired me. They said, don't come back now. We will give you some money, but stay away. What did Meena do? We were scared of the virus. What do urban slum informal settlements represent? The poor represent what? Dirt, disease, contagion. So they were labeled, and they've always been labeled and stigmatized. So Meena went, it was very, very heartbreaking to hear, in about May. She started getting desperate because the government kept extending the holiday. There was confusion, there's misinformation. She walked every day to Gulshan. She pleaded with the police who were there. The police and army were doing surveillance to have the country into lockdown. And she said, look, I have a little baby, I need to eat. The police would often let her go, because not every policeman is bad. But she would walk through there. Every time she was nervous, she said, I use my sari to cover my mouth, because masks were mandatory. And masks are also 30 taka. It's less than $1, but it's a lot for someone who may have to buy egg or eat something or buy. And food prices were rising, by the way. So here's Meena, who talked about blistered feet, torn sandals, and not getting a job. She did that day after day, week after week. She borrowed, so it was a cycle of loans, debts. She borrowed from the shopkeeper. She borrowed from her mother. She borrowed from, everyone was in a similar situation. Her mother's also a housemaid. So what do? You rely on an informal economy, networks of relationships you've built over time. It may be the tenant, it may be the shopkeeper down the road, it may be even your employer. So Meena was finally offered sex work, January 2022. She called me and she said, Appa, what do I do? Of course, I'm not going to take this, but I'm struggling. I get temporary jobs because everyone wants a full-time maid, not someone to come and go from slums. That's one story. So Meena has perpetual body aches, fevers, colds, backaches. There's Shuli, who's a hawker. She stopped being able to hawk because of lockdowns. When it all opened up, In November 2021, the city corporation went on a drive to remove hawkers from the streets of Dhaka, because we have to beautify a city. There might have been a upcoming visit, but we regularly have these drives. I've been working since 2000. You have these drives, you remove the hawkers, they pay a lot of bribes, they're extorted a lot of money, and then they manage to come back. She was arrested twice. Her family scrambled, her mother, one of her main supports, her husband, who worked on and off, found money, about a couple of thousand taka, which means another cycle of loans and debts. And then you have Fatima, who's 7 months pregnant, who also went back to hawking. She'd been working earlier, a bit more of a business she had before lockdown, but lockdown meant that a lot of the options had shut down. So at 6 months, she was 6 months pregnant as she walked the streets of Dhaka. I've been seeing these kids since they were 10 years old as hawkers. And they continue to hawk. Some of them graduated, whatever we call graduated, into garments work, or working in a shop, or setting up a tea shop, having some autonomy in their income. But many of them went back to hawking. Some, like Shuli's mother, went back to begging. Amidst this chaos, if I look at the stories of their lives, I'm still following them, talking to them, I know them, it's heartbreaking because amidst this chaos, they're dealing with landlords wanting rent, negotiating, navigating these spaces. Loans are piling, which means you have to pay off creditors. Yes, you can get loans from NGOs, but creditors often give quick ease of access. Then I said about food pricing. So support, informal networks are really, really important. So I want to talk about what health means in these contexts. Body aches, pains, fevers, colds. People talk about chest pains. Their husbands, in fact, I forgot to say, Fatima's husband was arrested twice because he tried to drive an auto rickshaw during lockdown because they were so desperate to earn an income. The law is the law, but it's different if you look at intersectional factors. It's about power, privilege, and politics. And they're so much at the bottom of the pyramid, of the hierarchy, that they're out of any economic social system. And they don't ever get a chance to be included in the economic system because, as Satchit said, they're constantly on a treadmill to survive. The precariousness of their lives is visible and it's disturbing. So what do we call public health when we look at disease inside the body, when we look at healthcare, which is important, when people cannot even, they're struggling to live every day. And it makes you think of human beings and the human dimension. COVID reminded me of shared humanity, an accountability, a responsibility, a moral responsibility. It's not the state. It's academics, it's researchers, it's activists, people working in this field. What is our accountability in terms of recognizing these invisible communities everywhere? It's not just Bangladesh, India, Pakistan. I'm working with colleagues in Nairobi. I'm working with colleagues in Sierra Leone. What do we say to them when we've actually led them to a domino effect where it's going to take a long time to undo because they're constantly just struggling? Life is unpredictable. Life is living on the edge. So public health really needs to unpack its biomedical discourse and really look at a holistic approach where structural inequalities and social systems need to be unpacked, critiqued. You know, we really talk about how long-standing evidence in poverty, need, and disease continue to remain unproblematized. We still talk about siloed interventions. We still talk about numbers and X is above poverty because they earn $1.90. We talk about multifaceted poverty. I'm sorry. I think there is an injustice in terms of how evidence is read. So I want to go into the value of data. It is critical to do longitudinal ethnographies. Social science research gives you those nuanced complexities. We need numbers, we need representation, but the real stories of people's lives who are constantly trying to survive. And this also requires us to think about moving away from piecemeal interventions to a radical reconceptualization of what we mean by interventions and short-term solutions, which means we need to really acknowledge the underlying causes. Today it's COVID. Before COVID, these people's lives were existing. COVID just magnified and exacerbated the inequalities. And I do think, as Basu said, we need to create new institutions. We need to challenge paradigms and really bring these voices forward. And I think that's an accountability and responsibility we have for those of us working in public health. Thank you very much.
Well, thanks to all three of you for these really very provocative and very thought-provoking remarks. I mean, there's, I'm sure, many questions, and I just wanted to draw some themes that I'm hearing across these three. I think there's a lot. But the things that I want to take away are, first of all three of you remind us about the need for solutions that reflect the place, that reflect the context in which the healthcare intervention is being conducted. I think all three of you speak about the complete illogical nature of what countries in South Asia did when the pandemic was starting by aping what was being done in Italy and North America, failing completely to recognize the dramatic differences. For example, Mushfiq speaks about the dramatic differences in the demographic structure of the population. You speak about the dramatic differences in livelihoods. We just simply willy-nilly borrowed, copied, and pasted a completely incorrect policy for our region. And I think the price and the cost of that is still being paid out. And on the other hand, of course, we completely ignored the fundamental strengths of our systems, the systems that relied on the foundation of community health workers, social connectedness, community networks of all kinds. We replaced that with a top-down biomedical system. I will still remember I was caught in the lockdown in India. It was a harrowing period. And I will never forget how we willy-nilly borrowed the idea of the ventilator as being the solution to COVID-19. Of course, not only now do we realize that ventilators probably killed more people than they actually saved, and ventilators have quietly now disappeared from the language of COVID relief, but that in fact, community health workers who were so critical have now been brought to Massachusetts. Many of you may not know, but Partners in Health has actually been deployed by the governor of Massachusetts to bring an innovation, of course, a frugal innovation that comes from many parts of the world, not least South Asia, to the richest country in the world for things like contact tracing and addressing vaccine hesitancy. And I think it also begs the question about what we think of as innovation. Because we're all so enamored by things that are technologically sophisticated, things that look very expensive, things that require Harvard degrees to do. Whereas in fact, some of the most beautiful innovations of all are things that actually come from the community. And I think all three of you speak to that. The second point that I take away, which is, of course, the importance of recognizing the social justice argument when we think about health. We all acknowledge that social determinants are very powerful drivers of health. And I think all three of you remind us that the poorest of the poor, which of course in South Asia is a big chunk of the population, are those that have very different lives, and understanding those lives is so critically important when one thinks about organizing healthcare. I think it's important to remember that there's been many people have tried to estimate, when health of populations improve, and you try and attribute these to different actions. It turns out that even the most optimistic attribution to health care is only about 10%. In other words, 90% of the improvement in life expectancy and other important health metrics is not due to what doctors are doing in clinics and hospitals. It's actually due to structural and social policies. And this is a little, it's quite humbling for a person who is in the medical profession to realize actually how small a role we play in the healthcare system when we think about population health. And I'm reminded of Michael Marmot's wonderful description. What really matters is not the cause of a disease, but the causes of the disease. And when we think of the causes, of course, almost all of them lie in structural and social drivers that Sabina, you particularly spoke to. And I want to just end my remarks by, all three of you remind us that what really matters is not the disease itself, but the social suffering that accompanies lives in South Asia, sometimes leading to a disease and oftentimes being the consequence of a disease. And that is what we should really be emphasizing, not the biomedical narrow focus that has dominated COVID-19. But as we look forward, how we can address social suffering in its entirety. Of course, the term social suffering is one that also originates from this university. My mentor, Arthur Kleinman, and of course, my former chair, Paul Farmer, have written evocatively about structural violence and social suffering. And I think it is so very important to actually bring those ideas into the conversations as we rebuild a healthcare system post-COVID. So I believe we have 10, 15 minutes? Yeah, okay, we have a lot of time actually for questions. And if there are any questions coming from Zoom, could I ask the people at the back to let me know? But for now, the floor is open for questions from Tarun.
Thank you all of you for wonderfully enlightening comments, and thanks, Vikram, for moderating. You know, I don't know much about medicine other than hanging around Satchit and being in a family of doctors and hanging around Vikram a little bit now. One thing that strikes me is, so several of you implicitly took the medical profession to task, or the regulators coming out of the medical profession saying we're excessively focused on biomedicine or pharmaceutical-centric care, et cetera. I think it's not clear how to go about moving away from that anchoring point. It's not at all clear. You know, Vikram and I currently are 2 of 4 co-chairs of a Lancet commission in India, and that's a tough struggle every day to figure out how do you move away from that, what we all acknowledge is a poor equilibrium. So I'm curious for any thoughts about how to do that don't take, you know, generations to pull off. The second thing I would say is that, and this may not be popular in this room, but that's never stopped me before, but there's no shortage of myopia to go around. The social sector is, in my view, equally guilty of a different form of myopia. And that has to do with unwillingness or inability to take, not for a second to decry the social suffering that all of you have spoken evocatively about. But for instance, in the commission that we're involved with, you know, it has I don't know, 150, 200 people. The minute anybody, and we've got some free market economists in there trying to take a very analytic view of how one brings in market principles, but these are rejected out of hand as per se inadmissible among people who care about suffering. And I don't see why people who study social suffering have a monopoly on studying social suffering. So I'm just throwing this out there.
What's an example of something that got rejected?
So for an example, if you say that, you know, so this commission is for India specifically, if you say that policies of government procurement follow age-old government fiat principles that have no basis in elementary Econ 101 reasoning, right? And someone, you know, we have the former deputy central bank governor of India on our panel, who, by the way, is a good health economist, also, who says we should have some basic market principles in allocating government budgets. It's effectively, I think, ruled inadmissible by a significant proportion of eminences on our panel. And I'm putting words in their mouths, so I won't take any names. But I think that's the sentiment. So a lot of what I feel like I end up doing, and I think Vikram ends up doing, is trying to get people to stop ruling out diverse points of view as per se inadmissible from the get-go. Because that's an exercise in stupidity, honestly, and a replication. You know, we've had universal health care, which is the ostensible aim of this commission, is to promote universal health care in India. We've had reports of universal health care going back to 1943, 45, 46, whenever that Bohr report was. And, you know, they're all sort of incredibly parochial and myopic when you go back and look at them, well-intentioned. So I wanted to put out that it is these you know, silos that bedevil us as much as anything else. And there is no non-guilty party here from where I sit as a bystander who's now becoming less of a bystander.
So thanks, Tarun. 2 questions, quite different ones, and one of them is really about how do we move from this narrative of narrow biomedical to the kind of broader, you know, biomedical plus social framing. And the second is, of course, about the tension in our region, which is not just true in India, between neoliberal or liberal economic policies and those that are driven by the social sector around how healthcare is organized. I think another point that Tarun might have alluded to, but implicitly, is of course a huge tension between private sector provision and public financing. I mean, this is of course in India at least the single biggest biggest source of tension, the role of private healthcare. But would anyone? Yes, Sabina, please.
Thank you. I was just thinking when lockdown happened, and we were, I was talking to colleagues, friends, people at garment factories. You know, Bangladesh has a history of good, successful, community-based public health models. You look at ORS and diarrheal diseases. You look at TB, which is public, private, and BRAC, working with government, with referrals through drug sellers, because 80% of the population go to drug sellers. I go to the local drug seller because it's quicker. One of the big discussions was when lockdown happened, the communities did not have a seat at the table, nor did they have a say. And I think even Dr. Martha Sen refers to participatory governance. Like, can we listen and learn and create these spaces? So that's one thing that I think it's important. I think we need to look at whether it's solutions or steps forward, and I agree. We need to listen to different, not only disciplines, but across sectors. And what happened in Bangladesh was very ad hoc and reactive initially. And it was a very clinician-led task force. Another thing that I think very long-term, if we want to look at how public health is defined, we've inherited a very Eurocentric version of public health. Biomedical, but we don't have a lot of discussions around what does public health mean in other kinds of contexts. How does Ayurvedic or other kinds of medicines, when it is qualified and works, what about local innovations? So when I first joined the School of Public Health, we copied and pasted from an Ivy League, and a lot of it was good. But over time, we've kept some of that good, but we've also adapted it and contextualized it too. A lot of learning from communities. And I think that's important. So curricula, because one of the challenges of biomedical is that certain disciplines that are important dominate. And then there's a value of hierarchy and evidence. And if we want to uncover these voices and want to work together to improve, you need to hear these narratives. My final point is we're working with community health workers because they are the bridge in Bangladesh, and they were struggling during COVID. And BRAC's working with the government, and our midwifery program was working with BRAC HNPP. We were doing research. But one thing I also realized that community health workers sometimes get overloaded. They become the heroines, underpaid, overworked, and mentally extremely stressed out. So we're actually launching a study looking at their mental and emotional health by looking at the human being of that community health worker, who then becomes an instrument of service delivery, because often we overemphasize service delivery, which is important. But if the people who are behind service delivery are not, well equipped, or we don't give enough support, there will be challenges. Yeah, thank you.
So I have a very quick, but narrow answer to your question, practical answer. Next, and it's a bit of a bureaucratic answer as to what we need to do, right? So I am going to the WHO next week, and it was a little bit of a ridiculous request, which is come to Geneva for a 2-hour meeting, right? And that was my initial reaction, but then I got on the phone to understand why this was important. So it turns out, one thing that the WHO learned during the pandemic is that behavioral science has been by the wayside, right? It's not really central to what the World Health Organization does or knows about, right? They're much more biomedical, right? And they've learned that, okay, look, behavior of humans is at least as important as the behavior of the virus for us to get a handle on this problem. And so how do you actually bring in behavioral science to WHO? It turns out there's a bureaucratic process, which is you have to have such a meeting and propose a resolution, right? To have have behavioral science become a more central, to allocate budget to it, and then member states have to ratify that proposal. So that's what this meeting is about. So I think we need to. Well, I guess the first step is go out there and help, maybe from academic institutions, we help the world understand that these are multidisciplinary problems, right? But then you have to have some change makers at those institutions to make real changes.
Satchit?
Very specifically answer your biomedicine question, where do we go from here? I think delivery has to be fixed, for the examples that I gave as well. We're delivering very poor quality care across the spectrum. The reason I pulled up that photograph of the sanitation station is, in the 19th century, mid-19th century, where we didn't know what was causing disease and there was so much cholera in London, it would be so fantastical to imagine that these huge, sewage pipes, bigger than sort of, railroad tunnels, were going to fix a medical disease. It seems just very obvious to us now. And I think as we look back, 50 years from now, 100 years from now, hopefully, one looks back and says, oh, they taught every schoolboy, more than girl, in South Asia to learn to cook in school, so they understood what food was going inside their mouths. Oh, look, they got everyone to actually walk more, make the cities more walkable. India and Pakistan cooperated to figure out how to clean up the air on their shared border every winter. And that's going to be 90%. If what is killing South Asia is non-communicable diseases, hypertension, and diabetes, our current development model is violently against all the determinants that feed into those diseases. So the conversations don't need to happen with just physicians on the table. I think we need urban planners and we need policymakers to understand what the social determinants are. Because like Vikram said, we will make no difference, no matter how clever our apps get, to what is actually making us sick in the first place.
So we have time for one more question.
Yeah, we have a few questions that are also coming in online. If I can pose one from the virtual audience as well.
Please.
Great. Honestly, there's a couple of questions that are on, so I'll kind of summarize it. But some of the guests are asking if the panel can quickly speak to some of the disparity in sort of how the pandemic affected countries like India or Bangladesh or Pakistan, either the unique challenges on a country-by-country level that are in South Asia. So, for example, how did the pandemic hit so hard in India, but comparatively in Bangladesh, perhaps less so? So, if there's anything commentary on that.
I'll just quickly say that it was an unprecedented economic shock. Like separate from what happened with the virus and how many people died due to the virus, the amount of economic harm that was caused is just like, ever since we've started collecting systematic data since the 1950s, right, relative to all recessions, it's just, it was devastating.
And I guess, one more thing to add, which we haven't heard about on this panel, but it is important to flag up, is the devastating learning loss.
Yes.
Across the region. I don't know how Bangladesh and Pakistan managed the school closures, but India has had the longest school closure since independence, one of the longest in the world, in fact. Yeah. And the learning loss is catastrophic. ACER, the group Pratham, which does surveys of learning, it's so shocking it's beyond description. It's almost like an entire generation has been lost by, and it's exactly the same. It's aping what happened in Massachusetts in India, closing schools. And ironically, Massachusetts reopened schools within a few months, realizing how rottenly wrong that policy was. They were thrown children under the bus, basically, and their parents as well. India continued for 2 whole years. So it's just the greatest tragedy, a region that already had such massive learning loss.
And a risk is now we pretend that it didn't happen, so kids are showing up in 6th grade classrooms with fourth grade learning, and so they're not going to learn anything else. So
no remediation plans at all,
Was there another question?
Any other questions in the room?
Well, one last question, Hitesh.
Well, mine was just more, well, thanks for the panel. It was amazing. So much to unpack, as you said. You could actually, so as a physician that worked on the New York City Task Force, worked with the CDC through the onset, I'm an ENT. So we were seeing the height of it all. You could close your eyes and everything you all have said applies to us. Lest anyone leave here thinking that South Asia was worse off. We were aping systems. We were doing what Milan did, what South Korea did. It took us 6 weeks. Once we agreed with the CDC to change the policies, it took 6 weeks to have them disseminate that data. And going back to your point, Vikram, the interesting thing was in terms of counting deaths, the joke in New York hospitals were if someone got hit by a truck, they were probably a probable COVID because incentivization was there to increase that. And we still have not unpacked the intersectional ramifications. That's where I would go with this is I love your optimism, but I share Tarun's myopic belief that society is myopic. How do you see this restructuring in South Asia when we can't even restructure it here as well? Or do you see that maybe these groups will work together to restructure healthcare delivery? Or Satchit, like you said, I tell you, I love your 3 crises. That was so aptly put. And it'd be great if we, 1 or 2 things that, how do we do it?
It's the way Tarun, Hitesh picked up the phone this morning when Babra Ali Saab couldn't join and had 3 wonderful speakers, I think there's a role for Jugaad, but we just need to validate the Jugaad we do in South Asia, and I think we'll be okay.
Maybe for our friends who don't know what Jugaad means. Does it have an English an equivalent? I don't know whether America has Jugaad. Does it? Improvisation, which of course we do all the time. So with that, I just wanted to say, sorry, Hitesh.
I was going to just add to what you asked, and I know we're just a little late, but I always think of when it came to great change in America, you all outlined what the need is, right? It's pretty profound. It's life and death questions. You also linked climate and health very effectively. I always think back to when great change came to America, there's this legend, which is partly true. All the civil rights activists met President Johnson in his office, and they mapped out what they wanted. And they said, this is amazing. They couldn't believe what the White House was agreeing to. And President Johnson came in and said, this is great. Now go out into the streets and make me do it. Because he was not going to be moved unless the politics was possible. So life and death issues, governments aren't falling anywhere. What is it that moves this change that you've outlined the need for in South Asia, which are, all 3 countries have democracies at some level?
Yeah, well, that's a question our commission is grappling with. How do we make health a demand for from the people? And honestly, this has been one of the great mysteries in South Asia, that health doesn't figure even in the top 10 list of things that people want when they go to the hustings to vote. I remember Abhijit Banerjee once presenting to us just before the elections in Delhi. They went to the different parts of Delhi and asked people, can you rank all the things that you would like your elected legislator to do for you? I remember controlling stray dogs was higher than healthcare. And I think probably that is, in fact, healthcare too, actually, controlling stray dogs. But anyway, just to round up, it's what I like to just summarize. It's impossible to summarize such an incredible wealth of ideas that we've heard today in this panel. But I just wanted to make an attempt. I think what we've heard very importantly is the need to harness local wisdom, the wisdom that occurs in our communities that are historic, that are traditional and contemporary, instead of adopting simply, without any consideration of a narrow worldview that comes purely from a scientific tradition. We do have a lot of knowledge that goes beyond science. The second is accountability, which is, I think, altogether lacking across the region. Accountability towards how healthcare is delivered. And finally, of course, always keeping a very strong focus on social justice in everything that we do in healthcare. So with that, I just want to invite all of us to applaud this wonderful panel for what we heard this morning.